Good afternoon from the Financial Consulate. I'm Roger Baer. This is a webinar about the newest new normal, about the effects of COVID-19 on our lives, both in our financial markets and at the grocery store, in the way we send our kids to school and where we work. What's so important about the normal or the new normal or the newest normal? Well, as humans, our brains try to ascertain what's normal every second. When we think about something that's normal, that's okay. But something that's not normal, or the new normal, is a cause for concern, is a cause for stress. Something that's not normal causes us to consider a fight or flight response. And those feelings of stress and anger, anxiety, frustration, vulnerability that we all feel, well, these are feelings that have spilled over into the financial markets, into our political discourse, and out onto our streets. So today, although we'd like to forget about 2020 and COVID-19, because COVID-19 is synonymous with vulnerability, frustration, and job losses, political unrest, and political discourse, I hate to wish our lives away, but I'll be happy when 2020 is in the rearview mirror, believe me. What do we expect from 2021? Well, we hope it's better, but unfortunately, the silver bullet in terms of the vaccine may not come to fruition. Not that I know when it will be here, because I don't, but I don't know that it's the silver bullet we're all hoping. We don't know when it will arrive. We don't know how effective it will be, and we don't know how quickly it can be manufactured, distributed, and administered. So we'll talk about COVID-19 with a couple of physicians in our first segment. We will speak to Drs. Ramin and Diana Malavi. Diana is the Chief of Pathology at the University of Maryland, St. Joseph Medical Center. And Dr. Ramin Malavi is a family practice physician with Park Medical Associates in Towson. And in our second segment, we will speak with Chief Investment Officer at the Financial Consulate, too many financials there, Chris O'Shea. But let's take a look at 2019, where we left it, and how it sets us up for a discussion about 2020 and beyond. In 2019, we were still enjoying what was a long-term economic expansion from the global financial crisis of 2008, 2009. The markets had been in a bull market since then as well. We were seeing low unemployment, very loose monetary policy from the Fed. Our economy was out of intensive care, but still needed support in the form of tax cuts, fiscal spending from the government, and loose monetary policy. We had great economic results in 2019. US bonds enjoyed a return of about 8.7%, global bonds 6.8%. The S&P 500 stock index of large cap US stocks up 31.5%. Small US stocks were up 25, global stocks up 26. And for the last 5 years, bonds had been up about 4% on average. US large cap stocks up on average about 14%, and global stocks up about 10%. So it had been a long bull market and a long economic expansion. We didn't expect COVID-19, nor did anyone, but it was coming, because on the way to our New Year's Eve parties on the 31st of December, health authorities in China confirmed that dozens of people in a place called Wuhan were being treated for a pneumonia-like illness. And the race to control COVID-19 was off. So 2020 began as 2019 ended. We expected an economic growth rate in the 2% range. Unemployment, which had peaked in 2009 at 9.9%, actually declined to about 3.5% early in 2020. So the labor market and the health of the labor market was a ray of sunshine in an otherwise kind of mundane outlook. Money was cheap. The US 10-year Treasury bond, which peaked at around 5% back in 2007, was now 0.7%. So China reported its first death from COVID on January the 11th, and they locked Wuhan province down on the 23rd of January. Our CDC identified its first case on January the 20th, and we now know there were cases much earlier than that. And the World Health Organization declared a global health emergency at the end of January. In February, the US saw its first reported COVID death, and we declared a national emergency on March the 13th. By the 17th of March, 2020, the virus was present in all 50 US states. In May, the US reached 100,000 deaths. And between February the 20th and March the 23rd, the S&P 500 stock index declined 34%. So infections in the US were now crossing 6 million cases, with about 200,000 deaths, and worldwide, about 28 million cases, with deaths nearing 1 million. All right, now we're joined by Chris O'Shea, the Financial Consulate's Chief Investment Officer. And actually, Chris, I think we can share that we're taping this Friday morning, and it's been certainly an eventful year. As you know, we previously have talked to Doctors Diana and Ramin Malavi about COVID-19. I did a little bit of an intro, but here's my first question to you. And you knew this was coming because I've been interested in this phrase. And the question that I have for you is, are we sleeping on a dynamite pillow? That's what I want to know.
Well, I like having a memory foam pillow myself, so a dynamite pillow is a little scary. But good morning. Yes, it is great to be here. I appreciate the guests that we have, and just to make this an informal yet meaningful piece for our clients and other listeners. So, and I would answer that question with another phrase that I hear on a regular basis through one of the outlets that we listen to, and that is, you know, if we were thinking that investing were easy, we would be really misguided, because it's not.
It's not easy.
Obviously, that question is, we heard that posed, is what's happening with inflation?
Right.
What's happening with all this money that's being created? The question's been asked for 11, 12 years, and now it's just being ratcheted up because to the extravagant of
spending
the Federal Reserve. And I heard an interesting piece that I've been mulling over since yesterday, where the analyst was talking about the Federal Reserve and the appearance by Jay Powell and the words that he used and the posture and projections that they're making. And the Federal Reserve is basically saying in 4 years, we don't think inflation is even going to hit 2%.
Right.
So, I mean, these are the people that are supposed to really know, and they were predicting rates were going to go higher for all those years, and they didn't. So they clearly don't know. Right? The investment community is not evenly split, but they're divided. Some are saying that inflation, moderate inflation come back. Some people say, no, it's lower for longer. Mm-hmm. So we have to keep our eyes on the horizon, look out for any signs of inflation. And now the question really is, because of the disruptions with the pandemic, there are some dislocations and there are some pockets of inflation. And yet, is that a transitory thing or a long-term thing? So
yeah.
Cut out.
Well, and just finishing up with my dynamite pillow, I just can't let it go. I tell you, And of course, the gentleman who brought this up was talking about inflation. He was talking about bond investors sleeping on a dynamite pillow, and frankly, and the guy's smarter than I am. I mean, he must be. He's on Bloomberg, but I don't think bond investors are sleeping on a dynamite pillow. I don't see, as you said, I don't see inflation out there. Haven't seen any. Don't think we're going to see any. But here's the thing for our clients. We are sleeping on a dynamite pillow if we are not being careful about our asset allocation, if we are not being careful about calibrating our investment objectives so that we can withstand market shocks like we experienced in February and March. So, all right, so I'll leave the dynamite pillow alone, and I think you were headed to dislocations or bubbles or disequilibria manipulation that's caused by the loose money of the Fed, no end in sight. So yeah, is that does that conjure up an issue or a problem for us?
Well, when you look at other nations who have done that, there is not a parallel with us in Japan. But when you look at all this debt and looking at current times, but you look at past times, past decades or past centuries, it isn't a great thing when people are starting to put more and more tinder, as if you will, just more money out there. Clearly, the Federal Reserve it's uncharted territory for us.
Right.
So it at least, we think, means slower growth in the future, because you have this overhang. So, but okay, slower growth. Well, you had slower growth in the years 2010 to 2020.
Right.
Things that were done. You had a lot of fiscal spending, deficit spending going on in the midst of the great financial crises. And you saw things that seemed to hamper the economy, but the economy still chugged along and did really well for that period of time. So I think a lot of this gets back to is the avoidance of binary decisions.
Mm-hmm.
People are putting everything in one particular area. Like you said, match your goals and objectives with the portfolio, a balanced portfolio, a diversified portfolio. And it's not even those things, because we think there's a time to play offense, if you will, with stocks, and there's a time to be defensive.
So I thought it was interesting, the observation that you made regarding the difference in the S&P between the capitalization weighted return year to date, essentially the top 5 stocks and the bottom 495 stocks. Let's talk about that a minute. And actually, I think that leads in then to the observation about whether we ought to be indexing or whether we ought to be using active managers.
I was thinking the very thing, and as an unrehearsed piece of this is that you do have, so the equal weighting is down 10, 11% as of last night's prices for the year. And yet the S&P is up 5% for the year. Mm-hmm. And so that's a divergence that you certainly want to be on the upside versus the down. Mm-hmm. Yet you, again, 495 companies. So that is, as we have really taken the really agnostic approach to is passive better than investing, better than active, is that we think they both work at times. Mm-hmm. So over the long period, passive investing, index investing, low costs, stay with what you have, diversified indices is clearly something you need to put in your portfolio. But we've seen the disruptions, and this 5 companies doing better than the 495 is, we think now for those active managers with great histories of really looking at the best companies, are sustainable companies that with talented management and sustainable processes and repeatable processes is that they can look through and sift through the rubble of the 500 companies and come up with the best. And so we have shifted more money into active managers than we have to passive, and think for a couple of years that probably is a good place to be.
And if we find markets or a situation where we can't find active managers or adding value, we'll index. So we're, as you said, we're open to doing either, and we should be. One other advantage to the passive side of the portfolio, as I relate to clients, is it is very inexpensive, it's very uncomplicated, and it's instantaneous. We can reweight or underweight, overweight or underweight the portfolio almost instantaneously. Now, we say that, how often do we do that? Well, not very often, but it is a capability that we have through this tool in our tool bag, which I think is...
And for taxable accounts, being tax efficient.
Yeah. I like the binary decision. I forget Chris, who said that? Who talked about the binary decision making and what that's about?
Sure. So the folks that you've heard that when it's put into that phrase in that context, it's more the tactical decisions, meaning, okay, we've got our overall strategy, but we think financial stocks are good to buy right now. And so we're going to put a lot of money on that. And that is if you're right, it pays off well. If you're wrong, it doesn't. And so, timing things, more and more, I like what one of the advisors that we listen to says, that investing is a process over time and not so much a point in time, because timing things is the most difficult of all things, and very few have proven to do that on a repeatable basis.
Right.
So if we're exposed in certain areas and financials are a part of it, financials are going to do well in that example, then we're going to participate in that. We're going to get a flavor of that without having to get the full strength of that. Because again, we're looking to invest the investing process over time and to benefit from the appreciation of the economy and certain companies. And so you get the pandemic where you have cyclicals, delivery services. There's a lot of companies that are just shining in this. FedEx had its biggest quarterly revenues in history. Yet you have other companies, clearly they're just talking about, hey, should the airlines declare bankruptcy? Should they not? Should they really take on all this debt? What are they doing here? So
Sure.
we think that those decisions are ones that we shouldn't get locked into, even though they have an appeal to them.
Sure. Almost, I would say, an emotional appeal, which is something we judiciously try to avoid. The emotionality of the current markets, the fear and greed on a day-to-day basis. In those discussions, actually, I heard that discussion regarding the airlines the other day, and I was very interested because it was preceded by a discussion about the letter shape of the recovery.
Yep.
And the letter that I think most resonates with me is the K. That is to say, we've got an economy where there are a bunch of haves, and you mentioned them, the delivery companies, the Amazons, service companies that have been able to not be dependent on a supply chain that ends up over in China, have been able to let their employees work from home and take advantage of those efficiencies. And a bunch of companies, the have-nots, which have not done well and are not recovering very well in this economy. And so it's a K, not a check mark, not a V, not a U, and not a square root sign.
I think that about covers the ones that I've heard too.
Yeah. All right. So speaking of markets, One thing that we talk about that helps us um, to be divorced from the emotions of the market is a word: rebalancing. Using the ability to rebalance the portfolio in accordance with some criteria that helps us do what is not intuitively obvious. Because intuitively obvious or emotion means if something is moving, if something is doing great, you buy more of it. And rebalancing implies the opposite, right?
It does, sure. And in tweaking that and doing it unemotionally, because again, we know through behavioral finance and the great work that's been done over the last 10 years, 15 years, just on the biases that we have, thinking fast versus thinking slow, that whole concept of if you have a gut reaction, then sometimes it's right, but oftentimes it's just that. It's really what your perception is, and it's getting away from what reality is. And so rebalancing does that. It's to say, you've got to come up with it. Okay, every certain period of time and certain moves in different levels of assets is that you're going to reshuffle. And yet in the context of that, we also know that there are certain factors that have done well, and momentum is one of those.
Mm-hmm.
Momentum just being in investing when something is doing well, it tends to continue. You don't know for how long, but I mean, you and I have been in this business a long time. And so we were brought up in the value investing is what you have to do to be successful over time. And so we don't completely get rid of that, but we know that, and you have a military background, and so you would know this better than I, but the improvise and adapt is that you do over time is that value has underperformed for a long, long time. The thought of there's certain, whether it's energy or financials or that the type of companies that need to have value unlocked and then the market realize that you can wait for a long time.
You could wait.
So,
Yeah, well, I mean, value is underperformed for longer than we've been wrong about inflation and interest rates. And that's a long time, a very long time. Well, Chris, let's wrap it up. Let me ask you about final thoughts. I have a couple of final thoughts, and then we're going to do a little housekeeping before we let everybody go. But any final
I think we've
thoughts
hit on a lot of the, I'm sorry,
right.
I think you've hit on a lot of the key parameters that we set up around us and around the process, because what we have here is we have a team approach, and we draw from not only all team members, but especially the most senior folks. Drew's been in the business doing this longer than you and I have, but collectively there's a lot of years in that. And so again, we've touched on a lot of those things. And so I think the most difficult thing for folks is, okay, I have reacted to the markets over time, emotional, and I've put money on the sidelines. And so what do I do with that money that's been on the sidelines? How do I get back in? And I think I would say first is that the most important thing to learn out of that is to try to avoid the decisions that got you there, because it goes back to your original that we opened with. And that is, if it became a dynamite pillow, well, let's remove that and let's put the memory foam in there, because you need to have your goals and objectives clearly defined, and then your risk, the volatility exposure and your sensitivity to that really gauged in, and to say, because these black swan events, so-called, things happen on a regular basis that shock the markets. And so don't let yourself get caught in that place.
Right. Yeah, the markets are going to be shocked.
Again, investing over time. A colleague of ours a couple of years ago would say that, in 25 years from now, whether you put money in today or 3 months from now is really not going to matter, right? Can you then just move towards where you want to be? And there are more opportune times to do that, but that's some closing thoughts.
Good, excellent, thank you. Well, relating back to the doctors Malavi, one of the things they said in the lengthy conversation that we'll share with everybody is that if there is one thing you could do, it's wear a mask. Of course, they talk about hand washing and social distancing, et cetera, but that if there was one thing, it was the mask. Wear the mask for COVID-19. If there is one thing you can do in your portfolio, it's exactly as you said. Get your investment objectives and stick to them. If you can stick to them, if you're correctly aligned with your investment objectives in your portfolio, when the markets are cantankerous, and they always are, your mask is your investment objective. All right, so let's do a little housekeeping here. I'm going to share my screen and add for our next webinar. So as we conclude each of our subsequent webinars, we're going to try to do at least one a month. The next is Friday, the 23rd of October at noon. It's going to be hosted by Drew, and it's on the top 6 financial myths versus reality. It's essential you need to know. It reminds me of that show. Let's see, The Truth Is Out There. What's that show called? I'll think of it in a second. So again, you can sign up for that. You can register. We will send you the link, and you can register for Drew's webinar in a month's time. Lastly, we wanted to thank everyone for their attendance today. We hope that our webinars that we bring to you are meaningful. We encourage you to share those with friends and family. Please don't hesitate to do so. We also would ask you to share your experience with the Financial Consulate. We grow our business best when we're referred by folks who are satisfied with our services, with the way that we help our clients achieve financial wellness. So for that, we thank you so much for your attendance. For the Financial Consulate and for Chris O'Shea, I'm Roger Baer. Thank you for attending.
Thanks, Roger. Thanks, everyone.
Bye. This is Drs. Ramin and Diana Malavi. And folks, thank you sincerely for joining us and taking the time to share your thoughts and observations about this public health crisis. I think I certainly am hungry to hear what you have to say, to kind of get a straight shot, not listen to the evening news. And the folks in DC, dare I say, they've got their own spin on it. So thanks again. I really appreciate it.
Thanks for having us.
Oh, you're welcome. You're welcome. So let's see. I'd like to start by getting your status report both from a public health point of view and from a primary care point of view. So Diana, you want to kick us off?
Sure, I can start with the public health perspective.
Okay.
So as everyone's aware, we saw this initial huge wave of cases in the Northeast, and it turns out this was massively underestimated due to limits on testing at the time. So antibody studies later have shown that we probably at that time, when New York City was getting hit so hard, were only picking up about 1/10 of the actual cases. That wave ultimately got controlled, and then it was followed by a large wave in the south of the US, which looked larger in terms of numbers, but probably really wasn't, just because our testing was more effective and more comprehensive at that time. That's also why the death rate looked lower in the second wave. It wasn't really, it was just that we were identifying more cases, so we had a larger denominator. So now we're starting to see spikes in the Midwest, and we're starting to see spikes centered around college towns. So pretty much anywhere that you'll find large gatherings of people not wearing masks, you're going to have outbreaks. So what this tells us is that the virus is still really everywhere. It can crop up at any moment. It can be controlled with public health measures. We've seen states like New York and New Jersey and a lot of the Northeast get a really good handle on it. But as soon as we kind of want to pretend that it's not there anymore, it can rapidly rebound.
So in other words, if we let our guards down it reemerges.
We let our masks down. Yeah.
If we let our masks down. I like that. I like that. So Ramin, how about from you, from a family practice, primary care point of view? How do you view the status of the crisis?
Well, I saw this really firsthand, the effects on people really of all walks of life, my patients and the patients of my partners in our practice. Early on, there were a lot of unknowns about this disease. It really was, of course, new, and it was confusing. There were a lot of mixed messages coming from our leaders and across social media. So what I saw a lot in my patients was a great deal of concern, a lot of anxiety, a lot of stress early on. We're 6 months into this now. I think we have a better understanding of what the disease is like and how it behaves. There's still a lot of stress. In some ways, it's higher because people now have been affected financially. Their health has been affected. They have loved ones or friends who've been affected. So anxiety is still a factor. But I'm also now seeing a lot more frustration that it's still with us and it's ongoing without any real end in sight, and a lot of sadness actually. It's affected people in many ways.
Sure. Sadness, frustration, in some cases depression, I'll bet.
Yeah. Mm-hmm.
Yeah, sure. So all right, we're 6 months into this. And as Diana said, if we don't let our masks down, we got a better handle on it. We are certainly frustrated. So what's the path forward? What do we expect? Diana, let's come to you. How do you expect this to play out?
Well, I'll let Ramin talk about sort of the medium term, and I'll kind of go long term. Long term, this doesn't really look like a seasonal disease in the way that flu is. Flu really goes away in the summer and comes back in the winter. Coronavirus has made it pretty clear that it's not going to go away in the summer. We were hit really hard this summer. So it's not clear if it's going to be, if we do see an increase in the winter, that may be because people are forced to spend more time inside. Or people are just getting really, tired of all the public health measures that we're having to take right now. So in the long term, this is most likely going to become just an endemic virus that circulates constantly, like other common colds and like influenza. Even the pandemic flu of 1918, after devastating the population in 1918 and 1919, it stayed around. It just wasn't nearly as virulent, and a lot of people had already been exposed to it, so it didn't spread as readily. So that's kind of the natural history of a new virus, to hit a naive population really hard and then gradually over years become less virulent and less widespread as more of the population gains an exposure to it and hopefully some immunity. So if we do get a vaccine, if it's effective, that'll obviously speed up the process of reaching this herd immunity threshold. If we don't get an effective vaccine, it could be years before we get to herd immunity, and it would be the hard and painful way with a lot of cases and probably a lot of fatalities. So we don't really know how long immunity is going to last in this virus because it's so new, but studies from other coronaviruses suggest maybe 3 to 5 years is a reasonable expectation.
Lovely.
Yeah. I agree. This is going to be with us. I think we're going to see an increase gradually in cases over the wintertime for the reasons that Diana mentioned. This is going to continue on like a slow burn. It's like a wildfire. There are embers that are going to be flaring into regional outbreaks from time to time, or even worse. I think we'll see kind of dips and swells until either a vaccine comes available or we develop general herd immunity. I think the good news is that the research is moving along pretty quickly. We're doing a better job at treating the disease than we did in the beginning. There's something like 150 vaccines in development all over the world. Hopefully one or a few of those will come through and be effective. And it's actually looking like now there's some data to suggest that maybe you can't be reinfected. So maybe people who have had the disease will have immunity, and that'll contribute to the herd immunity that Diana was talking about. So I think there's some good news, but I think it's going to be with us.
We need to settle in for the long term. This is not a sprint, it's a marathon, unfortunately.
Yeah.
I think we all have been sprinting. I've been sprinting. I just want you to know that. I'm done with it. All right, so if we're going to settle in for the long term, if this is a marathon, then face coverings, social distancing, hand washing, is that sufficient, or are there other things that we really should be considering?
Well, I think mostly those are the important things to be doing. You know, this virus can't persist if it can't find or spread to new susceptible hosts. I mean, that's really what needs to happen for this pandemic to continue. And if we are able to maintain social distancing, you know, it has a harder time spreading. We keep our hands clean, wash our hands regularly, again, has the effect. Mask wearing is really important. A lot of studies have shown now that masks do help to lower transmission. This has been shown in even in guinea pig studies. Interestingly, I don't know how they do that how they have
on a guinea pig. It's an image.
Yeah. Or I'm sorry, maybe it was hamsters actually, but
equally as difficult, I think, Ramin.
But yeah, the masks do make a difference, but the important thing though would be that they be worn properly. And I think we've all been out and seen people wear masks down below their nose or on their chins.
Sure.
You really need to wear them properly, and that means
I can demonstrate.
Okay.
Below your chin.
There you go.
Yeah.
Covering your face, your nose, and your mouth.
Yeah.
Right?
Yeah.
And this is important. The type of mask is also important, and you can find information online from CDC or World Health Organization on the kind of fabrics to use. You know, having a valve in the mask just doesn't, kind of defeats the purpose as well. But this is really important. You know, they protect you, they protect other people too. And there was just some recent publications coming out suggesting that even if you do get the disease, if you're exposed to somebody while wearing a mask, you may actually have a lower kind of a lower dose of exposure, and that may actually lead to milder illness. And
Gotcha.
This has actually been shown in other diseases as well. So there are benefits.
Go ahead, please. Please.
The other things I would say beyond those basics are that if you get sick, you got to stay home. This is an important part of not spreading the disease. And then finally, just take care of yourself. Don't neglect your routine health care. Exercise.
Self-care is important, and perhaps even more important during a stressful period, such as we're going through. Go ahead,
to
please.
that actually, just to reemphasize with masks that social distancing, as much as we concentrated on that in the early part of the pandemic, when it was really difficult to get masks and when no one was really sure if there was aerosol transmission of this disease, social distancing is not a substitute for a mask, and that's especially true in an indoor environment. So in an outdoor environment, there's a lot of ventilation and you can get away without a mask with social distancing. But in an indoor environment, something like indoor dining, an indoor movie theater where people aren't wearing masks, I think that is still one of the absolute highest risk activities you can do. So, you know, we talked a lot about social distancing in the beginning, but it's really been supplanted by masks, and masks are really, you know, above social distancing on the priority list. So it's not a substitute.
So you really, masks and hand washing then would be really the two preeminent behaviors, right?
Plus the distancing, but yeah, she's right.
Gotcha. So I have read recently, and I'm departing here a little bit from the questions, that there are a number of, I've been reading more about therapies that are successful. Ramin, you mentioned this, that as time has gone on, not only are we on track to find a vaccine, hopefully, but it sounds as though that there are more, we're having greater success treating those who are infected. Reading the other day where, you know, off-the-shelf medications used for other purposes are being used to treat COVID patients. And there seems to be, just anecdotally, the stories about folks spending less time on vents and in the ERs. Does that correspond with your experience?
Yeah, the treatments are primarily for hospitalized patients, and especially the most severe patients who are in intensive care. There still is nothing available for outpatients or people with mild illness, and there's nothing available yet for prevention other than what we've already talked about.
Right.
But yeah, for hospitalized patients, there are some things. Remdesivir, there are some other, some news about steroids in those situations. They have no role for outpatient
Gotcha.
affected people.
So Diana, we mentioned before as we talked the relationship, or the potential relationship perhaps, of COVID-19 to SARS and MERS.
Mm-hmm.
And I know you've called COVID-19 a novel, or the novel coronavirus. How can you explain a little bit of that to us?
Sure. Yeah. So the current coronavirus and SARS and MERS are all in the coronavirus family, which is a really large virus family. It's predominantly a family that's found in bats. There, other than SARS and MERS and Sars Co V2, there are 4 coronaviruses that show up in humans that really just cause the common cold. So they circulate around, they don't put people in the hospital, we don't test for them, they're just an annoyance. But in 2002, SARS-1, which stood for Severe Acute Respiratory Syndrome, jumped from either bats or civets, or both, to humans in Asia, and caused a really virulent pandemic that spread around the world. What made SARS very different, SARS-1 very different, is that it was a very virulent disease. People got it and they got very sick. And so it was pretty easy to trace, who had it and isolate people that were sick. And as a result, despite being designated as a pandemic, it only infected about 8,000 people worldwide, and then it was actually completely eradicated. So that was a success story. MERS is Middle East Respiratory Syndrome, also a coronavirus, also with an animal reservoir, camels, I believe, and it also has been found in bats, like most coronaviruses were. That one, human-to-human transmission is very rare, so that one hasn't really become a large-scale pandemic. This SARS, which is called Sars Co V2 because of its similarity to the original SARS, also called novel coronavirus, also called COVID-19, all these are the same thing, came from a recombination of a bat coronavirus that had some sort of small changes or mutation that made it really well suited to humans and made human-to-human transmission possible. The thing that made the current SARS epidemic so devastatingly different is that there was a huge asymptomatic population. So you had some people that were very sick and ended up in the hospital, a very high fatality rate, and yet there were also people who walked around without even knowing they were sick. And that's what enabled it to really just get all the way around the world, 5 times before anyone really realized what was happening. Those are the similarities of the same virus family, but this particular coronavirus has displayed a very different behavior than anything we've ever dealt with before.
And as you said, the virus could not cycle seasonally, but just continue to cycle through the population, right, for some time.
Right.
All right, so if we look back, I was looking at the news clips. The Chinese on the 31st of December reported dozens of people being infected by a flu-like illness in a place called Wuhan, which is now on the tip of everybody's tongue. So if we look back, what could we have done differently, Diana? Is that a loaded question? Go ahead. Let her go.
I mean, yeah, we could have, yeah. We could have done a lot of things differently, but I have to preface it by saying that every country in the world got blindsided by this. So we were not special in that sense. But it would have helped a lot in the beginning to have a coordinated national strategy for the distribution of medical supplies to hospitals, including PPE like masks and face shields and gowns and gloves, ventilators, testing supplies, nasal swabs we had a shortage of swabs for testing early on, medications, and then the test supplies themselves. So that was very chaotic. It was sort of every hospital for themselves. We also didn't have coordinated best practice guidelines that we could fall back on. So every governor had to really make their own public health decisions relying on their own public health departments, and those vary widely across the country in terms of the resources and the expertise that they have. I think the most unforgivable mistake, though, was allowing the response to the virus to become a political wedge issue. Such that defying public health guidelines became this sort of identity statement, and this continues to this day with fatal results. So I think that's what really separates our experience with this from that of other developed countries.
Gotcha. I mean, I was thinking driving in this morning, New Zealand seems to have done extraordinarily well. I don't know how frankly their approach to the situation was different than ours.
That was a remarkable story. I mean, they within 2 weeks of the declaration of the pandemic, the Prime Minister declared basically a countrywide lockdown and a national stay-at-home order. And pretty much they turned the curve of that disease within 4 weeks. And at the end of 7 weeks, they were essentially COVID-free. They went through about a 7-week lockdown, and after that, New Zealand was back to business. I mean, it was remarkable. They went through the summer COVID-free. They've had a little bit of a relapse now. It looks like from some individuals who may have traveled out of the country, but it really was a remarkable story, and it shows that it can be done. And you don't need a totalitarian government or to accomplish that kind of thing. So it is possible. Granted, it's a smaller country and they have other factors there, but really it's doable. I think the key thing is that they took early, decisive action, and it was based on science. The Prime Minister communicated with her people very clearly, and she was able to unite the populace toward this common goal, and it worked. So it's doable, and it's a shame that it couldn't happen.
Very unfortunate. Well, deadly is a word Diana used. I think it's very unfortunate that that's what happened. So
I would say, Roger, also just on a general scale, even without having a countrywide lockdown, just countries that had universal masking had less severe illness and lower death rates. I mean, just that alone does make a difference. And Diana said it's become really a political statement, and it's led to a big part of our problem that we have today.
So from a public policy, public health policy preparedness point of view, were we ready for this? Is there something that we should all think about to be more prepared for this sort of illness in the future?
Well, infectious diseases have been part of the natural order of things forever, and they always will be. New diseases come and go, old diseases come and go, sometimes in small outbreaks, and sometimes they expand to broader epidemics or wide-scale pandemics. But this is just part of human history. And even in the past 20 years, we've seen a number of outbreaks from SARS, swine flu, MERS that Diana mentioned, Ebola, you remember this, Zika, and now COVID-19. I mean, these are continuing to happen. So really whether an outbreak of a disease develops into a pandemic depends kind of on the nature of the disease itself, how well it spreads and how much natural immunity there is in the population, among other things. But it also depends on the public health response. So we can't do much about the nature of any given disease, but we can affect our public health response. We can be better prepared. But this really requires recognition. This is an issue. It requires a willingness to spend the money on being prepared and on having stockpiles of necessary supplies. We need politicians who make a disease response.
All right, so let me switch to something a little bit more personal. The kids, sending the kids back to school. My wife is I don't know if you know this or not, my wife is a high school teacher and out in Carroll County, Maryland. And they are completely remote, but seriously thinking about going back in session in some fashion by, say, middle of October. All right, if we go back to a previous conversation, if the kids wear masks, are we safe enough to bring the kids back to school? What do you think?
Well, so asking if it's safe for the kids to go back to school is kind of like asking if it's safe to walk around at night. Like it really depends on where you are and what the circumstances are.
Gotcha.
Too general of a question. And it's also difficult because there's really mixed data on what role children play in this pandemic. So the very earliest study from Wuhan showed that child to adult transmission was actually really rare. And we know that children generally are at pretty low risk from this disease, very extremely low complication rate in children. And many schools in Europe opened safely. Israel was cited as an example of why you shouldn't reopen schools, but it's really hard to interpret the data from Israel because they also reversed a lot of their other public health restrictions at the same time that they opened schools. So they did have a resurgence of disease, but it's really hard to know what role schools played in that. I personally feel like education should be regarded as an essential service. If we can keep Target open and we can keep the liquor stores open, we should have been able to spend our summer developing a way to keep the schools open.
Right.
But it's not realistic to expect every school district to reinvent this wheel for themselves. Or to create best practice guidelines. Again, we don't have this overall unifying best practice standards that schools can really, rely on and kind of use to back themselves up when they try to make decisions. So as a result, they have to go to the default to the most cautious pathway, which right now is still to just keep everybody at home. And also schools don't have the funding support. So schools that can't even get their water fountains fixed are not going to be able to install new ventilation systems and have access to viral testing for all students once a week, which is kind of what you need. So I think that it should have been possible to get all the kids back to school in a safe way, at least in areas where there's not out of control growth of the virus. But as a country, I think we didn't give the schools the support that they needed, so there was no way it could happen.
Gotcha. Well, now, of course, we're hearing on the news, colleges in particular are coming back into session. And the students are becoming infected and then being sent home. And I wondered to myself, hearing this, whether that was a mistake. Is that a mistake to send them back to transmit the virus to folks at home? How do you handle that?
Yes.
Yes. Yes, it's a mess. It's tough to handle. Yeah. Well, and of course, college kids. I remember it. It was a long time ago, but I was a college kid, and I was sure it was devil may care about lots of things. We didn't have a coronavirus pandemic when I was in school, thank heavens. So I don't know how I would have reacted. I don't think I would have wanted to wear a mask. We were all in very close quarters. That just goes with the territory in colleges and universities. So it's just another difficult situation to handle.
Among many.
We, Diana, you mentioned testing, and I actually skipped past the question regarding testing and how important it is, how difficult it seemed to be to get tested, and and the delay. I actually got sick. No, it's now been 90 days ago. Had a fever, did recover, but did get tested. But the test results took 4 or 5 days.
Mhm.
So now I maybe that was a different type of test. What about testing?
So there's only two types of tests that can be used to diagnose an infection. One is PCR testing, which is looking for the viral RNA, and the other is antigen testing, which is looking for the viral particles, the proteins in the virus itself. And the only test we had for probably the first 3 or 4 months of the pandemic was PCR. And in the beginning, this was a brand new organism we were looking for. There were a bit of stumbles from the CDC in rolling out this test, so that delayed things a little bit. But a PCR test like this one requires a really large molecular platform that most hospitals don't have. So, Hopkins had one, University of Maryland had one, LabCorp had that kind of testing, and Quest, and that was really about it. So all of the testing had to get funneled through those reference laboratories. And in the beginning, when LabCorp first started testing in mid-March, there were like 2 testing sites in the country, and there were about 500,000 tests coming in per day. So it maybe not quite that many in the beginning, but rapidly got to that. And it was just a logjam. They were just absolutely drowning in backed up cases. And at that point, there was a delay of about 10 days. And so gradually they've expanded their capabilities and they've expanded their testing sites, and now it's flowing a little bit smoother. Typically results are in the order of 2 to 4 days. But still, very few places have the instrumentation to do that test on site. And it's still really in this area, just Hopkins and Maryland, and then the reference labs, the commercial labs. The small portable tests that can be done in an urgent care center or a community hospital or a doctor's office are more dependent on cartridges. So the large instruments just take raw ingredients, and you can run a lot of tests with a few raw materials. But the smaller ones, the portable ones, are like cartridge based. So you need a test cartridge for every kit. And the inventory of those has been severely limited. It's just everyone in community hospitals all over the country is having the exact same problem. We have the instrument, we can't get the kits. So that's why it's so hard to get a rapid or same day test at most places in the country still. Is it just the inventory for the small portable test instruments is just not out there. Now in the past month, we've seen antigen tests come out, which are tests that are looking for the viral protein. They're not quite as sensitive as the PCR tests, but they're still pretty good. And a positive is still a reliable answer. And so we're starting to see those crop up now in urgent care centers. So most likely, if you go to an urgent care center now and get a rapid test, it's going to be the antigen test. And those are just more suitable to mass production. So they've been able to ramp up the inventory a lot more quickly on those. One antigen card test made the news a few weeks ago. That was this Abbott Binax Now. It was like $5 in 15 minutes, and everyone can get a test. And the federal government immediately bought up the entire inventory of those cards until 2021. So we're not sure how those are going to be deployed, but that, private clinics and urgent care centers and hospitals were really excited about that as a possible avenue for rapid testing, and now we can't get any. So it's been difficult and frustrating for everyone.
So this is a resource question, I guess.
Supply chain.
A supply chain question. A cost question, I'm assuming the cartridges are relatively expensive.
Yes.
But I also hear, or I think you said previously, that testing is an important part of the path forward. And I assumed when you said that it was important to identify in particular asymptomatic individuals in the population.
This is really important because asymptomatic folks can spread this disease as much as the folks who actually have active symptoms. And the only difference being that they don't know that they have it. It is important to identify those people if possible, which is also getting back to masking, why it's important to wear the mask, because you could still be ill without realizing it.
Without knowing it.
Yeah.
Right.
Yeah.
Good.
And also the other purpose of testing serves is that it can identify areas where you have early outbreaks and hopefully contain them.
Mm-hmm. I understand.
And one thing I would add too, building on that, is that you can be asymptomatic, as Ramin said, and you can also test negative even when you have the disease. All of these tests have a well-known false negative rate. So a positive test is really informative and tells you need to quarantine and tells you need to get in touch with all of your contacts and make sure that they can get tested. But tests at this point are not to where you can really rely on them for a guaranteed negative. So if you're trying to go visit an elderly family member or, decide, you can't really count on tests, especially rapid tests, to tell you you're negative. So it's not a shortcut around having to wear masks and having to use, social distancing and be careful and all of that. Like you just have to always keep in mind that you could have it at any time, even if you tested negative yesterday.
Gotcha. Yeah, I think I shared with you all, I was very sick and surprised that I tested negative and continued to stay home till well after the fever subsided, etc., because I really thought it was a false negative, and perhaps it was. We'll never know.
That's wise, and we'll sometimes try to get patients retested if we have a negative result in someone who we suspect really is sick.
So Ramin, so how has this affected your practice? At the primary care level, I'm assuming you're seeing a lot of folks by video, by Zoom or GoToMeeting, or how's that working for you?
Well, early on in the pandemic, we almost saw nobody in the office for nearly 2 months, and we really had to get up to speed on televisits, Zoom and other similar platforms, very quickly. That's changed now. People are better about understanding the disease and doing the right things in terms of masking and such. And we now have, we can get people back in the office safely. But it really has had a tremendous impact on medical practice. Our workflow from the moment a patient schedules an appointment to when they're seen in the office is vastly different from what it used to be. People are screened before they enter the building. Our front office is cleaned on a regular basis. We have screens up between the staff and the patients. We really try to limit the amount of time patients spend in the office. So many of us do part of our visits by telephone with the patient sitting outside or in their car. We have HEPA filters in the offices. We have to clean between each patient. Many things are different. And this is costly. It's time consuming. It's had a big change on how we practice
Sure.
medicine.
So you're in quote unquote, and it's a financial term, not a medical term. You're less efficient. I mean, it's cost you more. It's costing you more time. You can't see. I'm assuming you can't see as many people as many patients as you could before, right?
No, it's burdensome on our staff and on the physicians as well. Yeah, we're coping with what's our new normal. We're looking forward to the vaccine whenever it does come out. But I will say I've actually seen more retirement notices from doctors in the past 6 months than I have seen in a while.
Sure.
I think it's accelerating some people's plans.
Well, in the vaccine, I hesitate to say it, but the vaccine is not going to be a silver bullet, right? I mean, you all tell me, we don't know when it's going to be out. We don't know how effective it will be. And if every human in the world needs a dose, we need billions of doses. You can't manufacture those overnight.
And it may in fact even be the type of vaccine where you need 2 doses to be effective. So what you just said times 2.
Ugh.
So
this is definitely a marathon.
yeah.
So Diana, how about long-term care situations and hospitalization? I know this is really, if you will, throwing sand in the gears at the primary care level. I can only imagine what's going on in long-term care facilities and acute care hospitals.
Hospitals, yeah. I mean, hospitals just took an unbelievable hit this year. It severely impacted all the hospitals in the area, both in patient volume. You know, suddenly it was only COVID patients and nothing else because no one else wanted to be in the hospital. And even now, when you know our COVID census is actually down and people are starting to come back to the hospital, there's still all these other operational changes, just changes in the way we handle patients. You know, how much time a room has to be empty in between patients in the OR, the increased level of PPE, all the testing, and the impact of this crisis on the Maryland payment model for hospitals. You know, they have this global budgeting payment model where their revenue is capped. And so you get a certain amount of money to take care of X number of patients for the year. And then it doesn't matter how much the hospital spends, that's all they get. So that's a system that's been around for a while, and it was based on fairly stable numbers across the years. And now this is just completely, you know, thrown everything up in the air. So hospitals are just sort of soldiering on and doing what they have to do to take care of people, but they have no idea what long-term effect this is going to have financially. And there are hospitals that are tens to hundreds of millions in debt at this point.
Sure.
So
Operating in the red.
Yeah, it's going to be, it's a mess. Long-term care settings got hit very hard early on. You know, in the beginning of the epidemic, those of us working in the hospitals were really, really conscious about wearing masks at all times. You know, everyone at my hospital was 100% mask all the time by probably the end of March. Long-term care facilities are not taking care of sick patients. And so they weren't in that mindset of having masks on everyone. And it at that time wasn't clear that you could have 30 patients in your long-term care facility infected with COVID, and they might be totally asymptomatic and spreading it to everyone else. So the long-term care facilities, nursing homes and rehab facilities really just got slammed early on. And that's where a lot of the cases and a lot of the fatalities came out of. So they've also had a lot of changes in the way they have to manage people, but it's a really difficult problem because people are living in these facilities. It's not reasonable to expect that they live in a mask. And yet you have an entire communal living facility where it's really hard to keep coronavirus from spreading. So, they have to be really aggressive about testing. There's now state law that every resident and every staff member has to be tested every week. That's really expensive and logistically difficult. So it's fundamentally changed the way that long-term care places operate.
Well, in a population that has certainly vulnerabilities in terms of the disease by virtue of age and underlying health conditions, I assume.
Yeah, exactly. Absolutely.
Well, so wrapping it up, folks, and again, we sincerely appreciate your time. Let me ask you a personal question. How has this affected? You're both practicing medicine under pretty difficult circumstances, I would observe. How are you doing?
It's been a challenge. This has been a difficult 6 months. I would say in primary care, I probably worked hardest in the first 2 months of this pandemic than I have probably ever in my career, and interestingly had very few patients in the office to see. We just had to retool our entire practice, and with no guidance and no prior experience. So it was very difficult in the beginning. And that was a huge challenge on a professional level. At home, we have two children, and I think they've actually handled this remarkably well. I'm pretty proud of them. We're fortunate that we're we're both healthy, we're all healthy, we have resources to help us weather this, but it's been a challenge. Certainly other families have had a much more difficult time. A lot of families have had individuals get sick, and some unfortunately have died. It's really been a sad time.
Yeah, difficult, very difficult.
Yeah. We've been, I have been really grateful that our kids were teenagers when this happened, because both of us still had to work. And if we had had small children, that would have been untenable, if we'd had to stay home and get them through their homeschooling. So in that sense, we were really fortunate to have kids that could were old enough to handle themselves during the day. But yeah, it was extraordinarily stressful.
Well, folks, thanks so much for your time, and thanks for your service to the community. We sincerely appreciate it. Thank you.
Thanks for having us.
Thank you.
You're welcome. You're welcome.